Hi, I'm an antibiotic. My name is MONOBACTUM. That's generic. And for the brand names, I'm known as Aztreonam, Kyston, Tiogangco, Nocardicin A, and Teltoxin. My chemical name is or I prefer the chemical formula, which is C13H17 N5O8S2. My drug classification is anti-ineffective agent for the therapeutic, and for the pharmacologic, it's antibacterial agent. My pregnancy category is B. Animal reproduction studies have failed to demonstrate a risk to the fetus, and there is no adequate and well-controlled studies in pregnant women. My mechanism of action is I interfere with the bactericidal cell wall synthesis by binding to and inactivating penicillin-binding proteins. This binding causes the formation of elongations or bacterial filamentation, resulting in the cellulosis and cell death. Pharmacokinetics. The recommended dosing interval in patients with normal renal function is every 8 hours. For my absorption, Aztreonam may be administered intramuscularly or intravenously. Absorption after oral administration is poor. For distribution, I am distributed into the intravascular space and extravascular sites, including skin, muscle, and lungs. In the patients with reduced circulating blood volume, hemodilation secondary to albumin administration persists for many hours. In patients with normal blood volume, excess fluid and protein are lost. For my metabolism, the serum half-life of the drug in patients with normal renal function is 1.5 to 2.1 hours. For my excretion, the primary route of elimination is urine. Take note. Indications. Kyston is indicated for suppressive therapy of chronic pulmonary infection due to Pseudomonas aeruginosa in patients with cystic fibrosis age 6 years and older. Consideration should be given to official guidance on appropriate use of antibacterial agent. Another indication is treatment of Pseudomonas aeruginosa pulmonary infection, colonization in patients with cystic fibrosis, treatment of gram-negative endobronchial infection in bronchiectasis patient. Contraindications. General information. A false positive reaction for glucose in the urine had been observed in patients receiving Aztreonam and using Benedict solution, failing solution, and Clinitest tablets. This reaction, however, has not been observed with test tape. Another general information is the most important one is antibiotics are not or non-selective and may result in the eradication of beneficial microorganisms while promoting the emergence of undesired ones, causing secondary infections such as oral thrush, colitis, vaginitis. Any antibiotic may cause diarrhea, nausea, vomiting, anorexia, and hypersensitivity reaction. Viral infection. This is contraindicated to viral infection. Aztreonam does not treat viral infection or common cold. Prescribing Aztreonam in the absence of a proven or strongly suspected bacterial infection or a prophylactic indication is unlikely to provide benefit to the patient and the increased risk of development of a drug-resistant bacteria. Patients should complete the full course of treatment. Carbapenem, hypersensitivity, cephalosporin, and penicillin hypersensitivity. That is contraindicated. Patients with known and established penicillin allergy who received skin testing to determine if they will cross-react to azithromycin rarely have positive skin tests. and many such patients have received full therapeutic dosing with aztreonam without incident. Clinicians should be aware that it is certainly possible to have a cross-hype, and the manufacturer states that aztreonam should be used cautiously in patients with sensitivity to beta-lactam related antibiotics such as the mentioned above, due to the minor chemical structural similarities in the agent per sensitivity, but such as reactions do not appear common. Renal disease, renal failure, renal impairment. Contraindicated for those because it's excreted renally as unam. Therefore, in patients with renal disease resulting in renal impairment with glomerular filtration rate of less than 30 ml per minute or renal failure requiring dialysis, systemic dosage adjustment is necessary. Since aztreonam is known to be substantially excreted by the kidney, the risk of toxic reaction to this drug may be greater in patients with impaired renal function. Given the low systemic exposure after nebulization, clinically relevant accumulation is unlikely to occur. Nebulized aztreonam may be administered to patients with degrees of renal impairment. This is also contraindicated to colitis, diarrhea, GI disease, inflammatory bowel disease, pseudomembranous colitis, and ulcerative colitis. Practitioners should be aware that antibiotic-associated colitis has been observed to occur over 2 months or more following discontinuation of systemic antibiotic therapy. A careful medical history should be taken. Acute bronchospasm. In clinical trial, patients with increased forced expiratory volume in 1 second, or FEV1, during the 28-day treatment period were sometimes treated for pulmonary exacerbation when FEV1 declined after the 28-day treatment period. Healthcare providers should consider the patient's baseline FEV1 prior to aztreonam therapy and the presence of the other symptoms when evaluating post-treatment changes in FEV1. Another contraindications is children, infants, and neonates. Aztreonam solution for inhalation is approved for use in children greater than or equal to 7 years old and adolescents. Safety and efficacy of nebulized aztreonam in neonates, infants, and children less than 7 years old has not been established. Systematic aztreonam is approved for use in infants more than 9 months, children, and adolescents. However, systemic aztreonam is not approved in pediatric patients with septicemia and skin structure infections where the skin infection is believed or known to be H. influenza type B. Safety and efficacy of systemic aztreonam in neonates and infants less than 9 months has not been established. Another contraindicated there is pregnancy. Use aztreonam during pregnancy only if clearly needed. Data in aztreonam using pregnancy are insufficient to inform a drug-associated risk of major birth defects, miscarriage, or adverse maternal or fetal outcomes. There have been no adequate, well-controlled studies of the aztreonam in pregnant women. Aztreonam crosses the placenta and enters the fecal circulation in animal studies. With aztreonam for injection, there's no evidence for developmental toxicity or drug-induced changes in maternal, fetal, or neonatal parameters. Systemic absorption of aztreonam after inhaled administration is expected to be minimal. There are risks to the mother associated with cystic fibrosis in pregnancy. Cystic fibrosis may increase the risk for preterm delivery. Another thing there that is contraindicated is breastfeeding. Aztreonam is excreted in breast milk at a very low concentration after systemic administration. Aztreonam has been detectable in milk between 2 and 8 hours after an IM dose and 1.5 and 8 hours after an IV dose. Another there is geriatric, because elderly patients are more likely to have decreased renal function that will decrease aztreonam elimination. Renal function should be monitored. Systemic dosage adjustment made accordingly. Side and adverse effects. For severe, we have bronchospasm, gastrointestinal bleeding, toxic epidermal necrolysis, exfoliative dermatitis, erythema multiforme, pancytopenia, angioedema, anaphylactoid reaction, seizures, and more. For the moderate, we have elevated hepatic enzymes, wheezing, neutropenia, eosinophilia, thrombocytosis, erythema, phlebitis, pseudomembrosculitis, candidiasis, hepatitis, jaundice. And for the mild, we have a cough, nasal congestion, fever, injection site reaction, abdominal pain, vomiting, which is very common, rash, diarrhea, nausea, halitosis, squeezing, and more. One of them also is dizziness, insomnia, or vertigo, sometimes tinnitus, and this that follows. Let's go to the nursing responsibilities. Before making or administering the drug, nurse should check for allergies to beta-lactams, penicillin, cephalosporins, or carbapenems. It can be administered in IM, IV, or via inhalation. During patients taking MONOBACTUMs may experience adverse effects similar to other beta-lactam medications, so nurses should monitor for GI symptoms, skin sensitivities, and coagulation abnormalities. Monitor actual site of infection. Last is after administration, monitor for systemic sign of infection. Monitor the WBCs and monitor the temperature for fever. And if you have collected a blood culture, and also monitor the blood culture results if obtained. So that's it. I'm MONOBACTUM, an antibiotic, and I hope you'll never have to use me. Stay healthy and eat healthy. Take care. Bye.